Today we're going to demonstrate prosthetic gait deviations. This is going to be my prosthetic side.
Trendelenburg gait, or a lateral trunk lean, is a stance phase gait deviation that will occur due to weak hip musculature, especially the hip abductors or hip abduction contracture. A short residual limb can lead to this gait deviation, or poor balance overall. Circumduction is a swing phase gait deviation that could be contributed to hip abductor muscle contracture or weak hip flexors, as well as just a general lack of confidence in using the prosthetic knee. Suspension issues can also contribute to circumduction that can lead to an effective lengthening of the prosthesis. Vaulting is also a swing phase gait deviation. This could be contributed to weak hip flexors or just improper timing of hip flexor muscle firings. It could also be due to poor suspension, much like circumduction. If the amputee loses suspension, it effectively lengthens the prosthesis. In order for them to not catch the toes, they vault to compensate for that. Foot slap is a stance phase gait deviation. If this occurs on the prosthetic side, it's likely that the prosthetic foot or prosthetic components are not controlling loading response and allowing the foot to get to foot flat too quickly. If this is the case, this would be a good time to refer that patient to our clinic so we can examine the foot and any other prosthetic components that might be contributing to this issue. Terminal impact is a swing phase gait deviation that can occur if the amputee flexes their hip excessively. This will cause the prosthetic knee components to clash together to create an audible sound. This is something that you typically want to refer the amputee back to us for, because we might need to make some adjustments to the prosthetic knee itself. Drop-off is a stance phase gait deviation that can occur if the amputee has a knee flexion contracture, or if the amputee compensates with excessive hip flexion or internal rotation at the terminal stages of stance phase. Lateral and medial whips are swing phase gait deviations that you'll typically see with your above knee amputees utilizing a prosthetic knee. They both share similarities in that if the socket is not donned properly, then you could see a medial or a lateral whip. So you'll just want to make sure that your patients are putting their prosthesis on correctly. In addition, if the socket is too tight or if it's too loose, it could create either a lateral whip or a medial whip. So you'll want to double check that as well. If the patient is excessively internally rotating or externally rotating their hip muscles, then they could also experience these whips. Excessive heel rise is a swing phase gait deviation that occurs at the initial stages of swing. This is typically due to the patient overpowering a prosthetic knee or just generally flexing their hip excessively. A longer prosthetic sidestep or a shorter sound sidestep could be due to a painful socket, weak hip musculature, or just a general lack of confidence and weight bearing on the prosthetic side.
So today we're going to talk about volume management and prosthetic wears. We're going to start with shrinkers. This is an above the knee shrinker. They're going to want to pull it all the way up into their groin. It's very important that you get around the adductor roll and then around the waist. This is a BK shrinker. Until they get their prosthesis, they should be wearing it 23 hours a day. Once they get their prosthesis, they can wear it at night and wear their prosthesis during the day. This helps to control volume and help them be able to wear their prosthesis. So for breaking wear, once a patient receives their prosthesis, we will tell them to wear the prosthesis for 2 hours, take it off for 5 minutes and check their skin, ensuring that there's no rubbing, bruising, or bright angry red spots. If they have a bright angry red spot that's not dissipating in under 5 minutes, they need to come back and see us. Otherwise, they can continue on in the same fashion with 2 hours on, 5 minutes off, checking their skin for the next week, and after things are good, they can start wearing their prosthesis full time. My below the knee prosthetic mold, I'm going to show you how to don a locking liner. So you would completely invert the liner, like so. The liner always goes next to their skin, and then you ensure that it's flat, and you roll it on. Like so. Once the liner is done, then if they need to have socks in order to have an appropriate fit, they would start with a 1-ply sock. A 1-ply sock is your thinnest sock. You're going to put that on. Ours in particular are cut to length, so we would cut them when the patient is here to the particular length that we want and put it on. If the patient gets up to where they're wearing 3 1-plies, we then tell them to take the 3 1-plies off and put on a 3-ply. As you can see, the 3-ply is a little bit thicker. Then if they get up to 3-ply and 3 1-plies, we would tell them to take all of these socks off and put on a 6-ply. The 6-ply is thicker. It's an effort to reduce the amount of socks you have to add while still being able to accommodate volume loss. After you get the right amount of sock ply, then you would put on the prosthesis, like so, engaging the pin into the lock. As far as sock management goes, if a patient starts to complain of excessive pressure at their anterior distal tibia, their fib head, or the bottom of their patella, those are telltale signs that they need to add a sock. It can be as many as 1 or 3-ply depending on the sensation of the patient and the shape of their residual limb. The other thing to note is if you start to see excessive rotation of a socket, they will probably need to add socks, and potentially quite a few socks. If they're wearing too many socks, you can also see excessive rotation of a socket, and so you would want to make sure in the case of a BK that they are seated completely in the socket. In the case of an above the knee amputee, you want to make sure that their ischial tuberosity is on the seat in the back.
Alright guys, thank you so much for watching our video. I hope it's been informative and helpful for you guys. And if you have any questions, please don't hesitate to reach out. Hopefully we see you out there in the field and we can work as a collaborative team, physical therapists and prosthetists. I know we love to work together all the time to create the best patient outcomes. Thank you so much.